let's start with an AS occiput. Right? So we'll just start from top to bottom. So AS occiput, I want the patient to be as relaxed as possible in chair. In the notes, in the Gauntlet notes, it talks about heels on the floor. The idea is that the patient, and you can do this in the exam, you know, you want the legs to be extended out, heels on the floor, palms up. You want the patient not to be resisting you, all right? So as the patient, you want the patient to be as relaxed as possible. We're going to use the condyle block, all right? So we need to have a block, and there'll be a block in the room when you do your test. So we want the condyle block flat side up. Okay, we want the flat side up against the base of the occiput, supporting the lower cervical spine. So we'll place the block, okay, and we're going to stand behind the patient with an AS occiput. And so I'm going to have the patient lean back against me, so they're going to lean back against the block. Okay, so just imagine that there's a block here. And what we're going to do, we can do one of two things. I can bring the patient's chin down, okay? They have an AS occiput. I want to eliminate that. I want to get rid of the AS. So I'm going to bring the chin down, right, and pre-position the patient, okay? We could do it that way, or what we've been teaching in class is that you just look straight ahead. Good. And so she'll lean back against me, okay? And there's a couple of contacts that I can use. I can use a pisiform contact, or I can use this contact here, which is the proximal lymphalangeal joint, PIP joint, okay, on the glabella, just above the glabella. So I can make a contact like this. Okay. Right. My elbow's going to be in. I'm going to cradle the patient's head. Right. Or I can make a pisiform contact above the glabella. Okay. Stack the pisiforms on top of each other. Okay. If I do this, I'm actually changing the line of correction. So I need to stack the pisiforms on top of each other. I'm going to squeeze the patient's head. That gives the patient security. Right? They feel secure, they can relax. Okay. Then what I'm going to do is I'm going to ask the patient to tuck their chin. There you go. Okay. With the block in place, have them tuck their chin, and then the thrust is going to be A to P and S to I in a scooping motion. Okay. So, if the patient has an AS/RS occiput, okay, I'm going to place my contact over the supraorbital ridge, okay, about halfway, halfway, over the brow. Okay, I'm going to use my fifth metacarpal phalangeal joint. Okay, I'm going to place my contact there. Again, stack the contacts on top of each other, so your hands are going to be somewhat offset. Okay, we've already placed the block. Okay, have the patient tuck their chin down. Okay, and with an AS/RS, I'm going to laterally flex a little bit to the right. And now my thrust is going to be down towards the center of my body. It's AS/RS. If I have an AS/RS/RA, okay, the right side is anterior. I'm just going to rotate the patient's head toward the side that I'm contacting. All right. If it's AS/RS/RP, I'm going to rotate away from the side of contact, and then I'm going to thrust the same way. So the thrust is exactly the same. All right. Questions about that? No? Okay. So for PS occiput, I'm going to contact with this part of my hands, thenar contact, okay? And I'm going to be in the mastoid groove. You guys can palpate that little groove above the mastoid process, okay? And so I'm going to place my contact right above the mastoid process. My thumb should be behind the patient's ear, but somewhat in front of the mastoid. Okay, so for a PS/RS occiput, it's going to look like this. I'm going to favor that side just a little bit. I'm going to turn my body a little bit, all right, if I'm doing a PS/RS. Okay. I'm going to support this side. I'm going to have the patient just lean back a little bit, okay, and I'm going to do a little bit of lateral flexion, and then the thrust is going to be just like that. Okay. This would be a PS/RS occiput. PS/LS occiput, I'm just going to turn my body on the left side, make my contact. Okay. I'm going to have the patient lean back a little bit. I'm going to laterally flex, and then the thrust is going to be like that. So there's no rotation, just a little lateral flexion. Okay. So that would be a PS/LS occiput. Okay. What do you think? Easy stuff? Okay, good. Did you notice the PS occiput is along the plane of the motion that we do? When we do motions, we're going to do motions up and out like that. All right. And the thrust was along that same plane. Who's getting the phone calls?
That's probably me.
Yeah.
To the tablet.
Okay. All right, questions? No? Okay. Traditional Gonstead thumb contact for Atlas. Okay. So I'm gonna have you guys just squeeze your thumb against your hand, all right? We're gonna make our contact with the pad of the thumb, and our contact is gonna be on the anterolateral aspect of the transverse process of atlas. This would be for a right atlas, let's say an ASR, okay? I'm gonna stand outside the chair, all right? So which means that one of my legs could be within the legs of the chair, but I'm gonna stand to the side of the chair so that if I lean forward, I'm not pushing the patient's head forward, all right? So I'm gonna make my contact. I'm going to slide my hand on the zygomatic arch. I'm going to take my fingers and wrap my fingers around the back of the patient's head. I'm going to ask the patient just to kind of lean back a little bit. I've got her now, okay? And what I'm going to do is I'm going to laterally flex by pushing in with my contact and lifting up with my support hand. Notice the patient has a third point of support. She's leaning against me, and my arm is against my upper body, okay? So the thrust with this one for ASR would just be lateral to medial and S to I. If I had an ASRA, I'm going to rotate the patient's head towards me, and I want my contact, my hand, to pivot on the transverse process. And so I'm not going to move my contact arm. I'm going to keep my contact arm in place. I'm just going to pivot on the contact. So now I'm on the anterolateral aspect of the transverse process. The thrust is going to be the same. An ASRP is where I rotate the patient's nose away. And so now I'm on the posterolateral aspect of the transverse process, inducing some P to A in my line of correction. So, okay. All right, questions about that?
Your thumb contact with that, you've got it braced up against your hand, and then you're using the
pad of the thumb.
pad of the thumb.
Yeah.
You do a marble shoot
On this side? So my contact is going to be against this, is going to be on the transverse process. Okay. Have the patient lean back a little bit. I'm going to laterally flex. Okay. This would be an ASL, okay, just like that. ASLA, okay. ASLP, like that. Now the thrust is going to be exactly the same. What else will I do when I make the thrust? Torque. Yes, I'm going to torque. When I torque, I'm going to move my fingers superior for a superior torque. I'm going to move my fingers inferior for an inferior torque. Okay. It's not a tremendous amount of movement. All right, we're just going to move our contact and our hand just a little bit.
Can we do a marble shooter contact on that?
You can, yes. Yeah. When you talk about the marble shoot, you're going to be here?
Mm-hmm.
Yeah, that's fine. That's fine, yeah. As long as you're not punching the person in the back of the knuckles.
That's supposed to do it.
That as well. Okay, questions about that? All right, diversified for atlas, okay. A diversified atlas adjustment is just for a left posterior or a right posterior atlas. There's no, there's a lateral adjustment with a lateral index, but the hands just get real funky and it just doesn't really work very well. So the posterior atlas works best. And so what we're gonna do is we're gonna use a lateral index contact in the hip joint on the posterior arch. And so for a diversified posterior atlas, I'm going to slide my contact down onto the posterior arch. Okay? I'm going to support the same way on the opposite side. I'm going to ask the patient to lean back a little bit. Okay? I'm going to laterally flex and rotate, and the thrust is going to be just like that. So that would be for an LP, an RP atlas. Have the patient lean back, laterally flex and rotate. If you need to step around a little bit, that's fine. Keeping your elbow and your arm close to your upper body, and then the thrust is just going to be straight P to A. That is the same way that we're going to do the lower cervicals diversified. Okay, so lower cervical diversified. If I have a PR listing, I'm going to contact the left lamina, and I'm going to do a tissue pull from the spinous out to the lamina. Okay, this would be a right listing. Okay, have the patient lean back a little bit, so a little bit of extension, a little lateral flexion, a little bit of rotation. Okay, and this would be for a PR lamina contact. Okay, diversified. For spinous contact, it's going to look very similar, but my contact is going to be on the lateral aspect of the spinous process. So I'm going to go from the lamina, I'm going to push down against the spinous process. All right. So for spinous process, this would be for a PR, okay, or maybe a PRS. I'm going to slide my contact down against the spinous process. Okay. I'm going to let the patient relax back. I'm going to laterally flex and rotate. Okay. Now my thrust is against the spinous process.
So
PL.
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 Sorry. PL. Getting ahead of myself. So that would be a PL or PLS. So, yeah. All right, what do you think? Pretty easy so far? It's all familiar. You guys know all this stuff. You guys been practicing this stuff every day. Every day. Yeah. Hopefully you have been practicing every day.
Affirmations.
I practice every day. So, okay, so traditional Gonstead is in the lower cervical spine. I'm going to stand somewhat angled, all right? And I want to make a contact on the spinous process. You're going to hook up underneath the spinous process with this portion of your finger, which is the distal lateral portion of your index finger. All right, so we're going to hook up underneath the spinous process. Okay. What we're going to do is we're going to have the patient. First of all, what we'll do is we'll flex the patient's head forward, find the spinous process, hook that contact. Okay, put the patient's head in a neutral position, and I'm going to stack the vertebrae. And then I'm going to extend the patient's head back until I feel that spinous process move. Okay, that's engaging the spinous. Okay, and then what I'm going to do is I'm going to laterally flex the patient's head to where they're contacting my thumb. I'm going to create that little rat hole. Okay, and so my thrust now is going to be just straight P to A. Okay, straight P to A, and I'm going to lift the segment. I'm going to lift the segment back into place. Okay, so it's a thrust, and I'm going to lift. Okay.
You're touching on the spinous.
I'm on the spinous process. Yeah. Yeah. Question about that? Yeah. So the alternative contact, lamina contact, I'm just going to slide out onto the lamina. It's the same thing. So I'm going to flex the patient's head forward, find that contact, go from the spinous, slide out onto the lamina. Okay. And put the patient's head in neutral position. I'm going to stack the vertebrae. Extend the patient's head back until I feel that lamina move. Okay. I'm going to laterally flex the patient's head, and now what I want to do is I want to have a P to A line of correction, okay, right through the plane of the disc with a little bit of a scoop or a little bit of a lift. I'm going to lift that segment back into place. So I'm going to move my wrist just a little bit. So,
What was this called again?
what's that?
What was this?
Lamina.
This was a
Contact.
lamina contact, so this would have been a PR-L. Mm-hmm. Yeah, PR-L. Okay. I think I covered all the cervicals. What did I leave out? Did I leave anything out?